Craniofacial cleft classification. So craniofacial clefts are abnormal discrepancies of face and cranium. So here in this presentation, we would be focusing on the classification system of craniofacial clefts. But to start with, we'll be focusing on the embryology, then we'll be having a brief idea about the theories of craniofacial cleft development, and then moving further about the various classification and in detail about Tessiers cleft. So this is the embryological perspective of development of the face. That is, it consists of um, five facial processes. That is, the green one is your frontonasal process, this is your maxillary process, and this is your mandibular process. So the frontonasal process gives rise your medial nasal prominence and your lateral nasal prominence. So the fusion of the medial nasal prominence bilaterally gives rise to your upper lip and the premaxilla. The fusion of medial lateral prominence and your maxillary process laterally gives your lateral side of the lip, and the lower part, which is your fusion of the mandible, gives rise to your mandible as well as your lower lips. Okay, so this is how it starts, and the the facial process development starts at 27th week, and then it forms this is how it looks in the 33rd day, and finally the fusion occurs by 46th day. Okay, so the main theories behind the development of the facial clefts include three. That is, the first one is failure of fusion, which was given by Tessiers in 1869, which states there is a failure of fusion and which leads to fusion of the facial processes, which leads to your craniofacial clefts. And the second one is the failure of penetration. So the proponents of this theory states that there is a failure of penetration of the mesenchymal cells, which in turn leads to the formation of your facial clefts. And the third one is neuromeric theory. Here it states that basically the basic concept behind this theory is all the bones in the soft tissue of the face are thought to be genetically determined. Okay, they have a particular field and spatial orientation wherein it has to be formed. So these are all genetically determined. So this is called mapping of the face. Okay, mapping of the developmental zones of the face. If there is some problem associated with the development of this genetically determined mapping system, there could be a facial craniofacial cleft, is what this theory states, and it is one of the most commonly accepted theories yet. Okay, and from this we would be looking into the classification. So moving forward, these are the classification system. That is, the first is given by American Association of Cleft Palate Rehabilitation. So which states craniofacial clefts are into four categories. The first one is mandibular process clefts, so which is the problem in fusion of the mandibular process. So there is a cleft in the lower involving the lower lip and the mandible, and the second is nasoocular cleft. So here the cleft runs between the nasal region and the ocular region, and the third one is oroocular cleft. So this again was later subdivided into the medial oroocular cleft and the lateral oroocular cleft. So this was based on if the cleft is running medial or lateral to the infraorbital foramen. And the fourth one is oral cleft, wherein the cleft runs between the oral region and the auricular region. So mainly the Tessiers cleft, those range of clefts comes into the fourth type. So the second type of classification is Van der Mullen classification. So this is based on the embryological development. So this states there are four types, that is internasal, nasal, nasomaxillary, and maxillary. So these are the four types. And the fourth one, that is the maxillary clefts, again is divided into medial and lateral. So to name it again, internasal and nasal is the second type, third is nasomaxillary, and fourth is maxillary. Okay, coming to the final one, that is the Tessiers cleft. We'll be looking into it in detail. So it was given in the year 1976 by Tessiers. It was given by Tessiers in 1976. So here, so this classification system follows a well-defined uh, mapping system, that is zones of the face. This is based on well-defined zones of the face and the orbit. So this correlates with the embryological developmental map. So as we had discussed, there is mapping of face. So this particular classification system correlates with those embryological developmental maps. So here in this classification system, there is a correlation between the soft tissue cleft, which can be seen clinically, and with the bony involvement, so which can be seen in the radiographic or the CT evaluation. So this also says that there is not, like, the soft tissue and the bony involvement might not be similar. Okay, the extent might not be similar. When we consider the initial cleft, that is 0 to 4th cleft, they have more of soft tissue involvement, and from 5 to 7 there is more of bony involvement. So we'll be looking into detail what are these clefts, but as of now 0 to 4 has more of soft tissue involvement, 5 to 7 has more of bony involvement. Okay, so another thing is here this Tessiers cleft is based on one of the most vital thing, that is orbit, and eyelids is considered as horizontal axis. So why? Because orbit forms both part of upper, that is the cranial region, as well as the facial region, that is lower hemisphere. So it belongs to both face and the cranium, so it is considered as the horizontal axis in the classification system. So moving forward, so this is the classification system. So we have broadly the clefts as the one here, that is 0, 1, 2, and the 3 extends from here, 4. I'll explain from where exactly in coming sessions. Okay, 4, 5, 4, 5, 6 goes here, 7 and 8 comes in the lateral region, 6, 7, 8. The cranial extents are from 9 to 10, 11, 14. So how do we discuss this? So as we had seen in the previous slide, so the facial involvement, it is in a combination, that is the facial cleft which is numbered as 0, which is in the midline. Actually, before this, let's discuss about four types of Tessiers cleft in a broad perspective for a better understanding. The first would be midline clefts, second would be paramedian clefts, third would be orbital clefts, and fourth would be lateral clefts. So the first one, midline cleft, consists of 0, which is in the maxillary region. Okay, and the number 14, which comes in the frontal, that is the zeros extends cranially, that makes your number 14. Okay, and you have number 30, which comes in the lower part, that is mandibular involvement. So 0, 14 and 13 makes it the midline cleft. So next comes paramedial cleft. So this is 1, 2 and cleft number 12 and 13. So 1, 2, 12, 13 makes it paramedian cleft. So we can see here these both are paramedian clefts. Okay, coming to the next one, that is 3, 4, 5, 10, 11 and 9, 10, 11 makes it orbital cleft. So this is your orbital cleft, this is your paramedian cleft, and this is your lateral cleft. Okay, and this is your midline clefts. So with the 30th number makes it midline clefts for easy understanding. So 0, 14, 13 is your midline, 1, 2, 12, 13 is your paramedian, 3, 4, 5, 9, 10, 11 is your orbital, 6, 7, 6, 7, 8 becomes your lateral clefts. So of this, how do you know which is which pair? That is, the extent of 1 is 30, extent of 2 is 12, extent of 3 to the cranial region is 11, extent of 4 to the cranial region is 10. How do I remember? Just addition of both becomes your 14. So 0 plus again 14, 1 plus 13, 2 plus 12. So this is how you remember it. It counts for all the clefts. 7 doesn't have a pair, so 7 is 7 plus 7. If you remember, 7 is an alone. It doesn't have, because it is an at most lateral cleft. So moving further, so this is how the involvement is. So 0, 14 and 30, your midline cleft. 1, 2, so the extent of which would be 12 and 13, cranial region, that is your paramedian. Okay, and the next one, 4, 5, 6, 9, 10, 11 is your orbital. So this is another question which could be asked. So the 4, 5, 6, 9, 10, 11 makes your orbital cleft with 6, 7, 8, which is the lateral cleft. Okay, coming to the first cleft, that is your cleft number 0. Okay, so this is also called median craniofacial dysplasia or centrofacial microsomia, frontonasal dysplasia, medial cleft face syndrome, holoprosencephaly. So the deficiency, it can be a deficiency, it could be a normal tissue which is just separated, or it could be excess of tissue. So each belongs to the same tissue, 0 cleft, of which the range could be from deficiency, normal, to the excess. Excess is called frontonasal hypoplasia. Deficiency is called prosencephaly. So the range of this deficiency would be, that is the tissue deficiency would be, it can range from a simple hypoplasia with hypotelorism to a severe cyclopia with ethmocephaly. So here, in the presentation of the patient, as we can see, would be there would be a false median cleft. As you can see in the clinical picture, there is a false median cleft. That is, there is absence of premaxillary segment, that is filtral column. All these things are missing exactly from this. So this premaxilla is either missing completely or it's absent. Sorry, it's abnormal. So most of the time it is absent. So which defines, that is why it is called false median cleft lip. Okay, so this is one of the significant feature of number 0 cleft. So with this, another presentation is there is no septal support, because the septum, which is a middle portion of, I mean midline derivative, also is abnormal. So there is no septal support. Because of this, the nasal tip is depressed. So there is a midline depression you can see here. So this is one of another important presentation. So coming to that, so to summarize, so the important clinical feature would be, so the skeletal involvement, you could see clearly there is absence or discrepancy in the premaxilla formation, and the septum is deficient, and the extent of it would be number 14, so which presents us the cleft in the frontal bone, the cranial bone. Okay, so clinical presentation, the baby may not be showing the skeletal abnormalities, because when the patient presents, they are presenting with false cleft lip without the premaxillary segment, that is the philtrum, columella, everything is absent. So this gives an impression of cleft, midline cleft, but this is false midline cleft. Moving further, coming to the number 1 cleft. So this number 1 cleft is a paramedian cleft. So to talk about this is similar to the common cleft lip, okay, which occurs through the cupid's bow. So there is a cleft. So in this presentation, patient doesn't have a cleft. Instead, there is a minute soft tissue involvement, which we'll be discussing later. But as of now, the patient does not have a lip. So the usual presentation of a number 1 cleft would be, it will be similar to the normal cleft lip, which passes through the cupid's bow, and in further extension, it would pass through the alar cartilage dome, and then to the soft tissue, nasal soft tissue triangle. It would involve, leading to a notching. We can see here there is a notching in the soft tissue nasal triangle. So there is a mild notching in this. So the patient might just present with this, but when we consider a CT or a radiographic evaluation, we would notice the full-fledged number 1 cleft. So the skeletal involvement in number 1 would be keel-shaped maxilla is present. Okay, so the extent is between the central incisor and the lateral incisor through the piriform aperture, which is just lateral to your spine. The spine is not involved, it's just lateral to the spine, and it passes further upwards through the junction of the nasal and the frontal bone. So nasal bone and the frontal bone's junction, it goes through this. Okay, I mean it involves this region and goes even further forward. If it is number, which one, it would be number 13 if there is cranial extension. So in this case, any which ways, with 13 or without 13, it leads to an asymmetry in pterygoid plates. Lesser and greater wing of sphenoid is also asymmetrical. Anterior cranial fossa is also asymmetrical. So this is a skeletal presentation. To summarize, between central incisor, lateral incisor, through the piriform, just lateral to the piriform, anterior nasal spine, in through the piriform aperture, in the front junction of frontal and nasal process. It further extends as number 13. There is asymmetry of pterygoid plates, lesser and greater wing of pterygoid, and the anterior cranial fossa. So if we consider the soft tissue, as we had discussed, it is nearly normal to your normal cleft lip kid. That is, the clefting of the upper lip is present. It passes through the alar cartilage dome. Then further upwards, it involves as a notching in the soft tissue triangle of the nose. Okay, and then the columella might be short and broad, and the nasal tip and the septum deviates away because of the less support in the cleft side. It deviates away, the nasal tip and the septum. It goes away from the cleft. Okay, and coming further here, we can see there is telecanthus. This is also associated with medial canthal attachment is ligament is medially placed. So here, which presents as telecanthus. Okay, so this is simple. The next one, going further, is your number 2. So here the cleft is, the bony involvement would be, it involves between the lateral incisors and central incisors and the canine. So, sorry, it involves between the lateral incisors and the canine. So from here, it involves the piriform aperture. lateral to the septum. So the septum is not involved. At the same time, the maxillary sinus is also not involved. So it's just in between these, and it moves further, okay, to the frontal nasal bone region. Okay, so this presents as hypertelorism when we see, so I mean, when we see clinically the patient presents with all these things. Okay, and also there is involvement, like as we said in the previous case, the lateral pterygoid, sphenoid, all these things are involved, and the cranial base asymmetry is also present. Okay, and when we consider the soft tissue presentation, the clefts here, the patient again do not have a cleft, but this presentation here also determines your soft tissue. Like this patient might present near normal to the other normal kid, but with few of the features like telecanthus, and there is mild nasal asymmetry. When we consider a CT and EC radiographic evaluation, we might encounter a cleft like this in the similar side. So the soft tissue presentation, which might be minute but has to be noted, is there might be a cleft which is involving the lower lip, that is lateral, which is similar to normal cleft lip. Okay, and after this, that is the paramedial cleft. After this, it might involve into middle third of the alar rim. So here alar rim is involved in the middle third. Okay, this is to be noted because in first one we saw that there is just a notching of the soft tissue triangle of the nose, and here it involves the middle third of the alar rim. And when we go to the third slide, there is alar base displacement. So this is the difference. The first one there was notching, second one there is involvement in the middle third of the nose, alar rim, and the third one there will be alar base displacement. Okay, so after this the presentation would be eyelids will not be involved in these cases, but instead they would just present with telecanthus, and also the lacrimal duct is not involved. Okay, the cleft passes just medial to the palpebral fissure, so the lacrimal duct is not involved. Okay, moving further, we'll consider. So this is how what all about the number two cleft. This is irrelevant because the patient just might present with few of the features like a simple telecanthus, but then patient might need treatment based on the supplementary, sorry, CT evaluation. Continuing, this is number 3 cleft, which is also called the Morian type 1 cleft. This is one of the commonest cleft. Okay. So Tessiers oro-naso-ocular cleft. It is commonly called as oro-naso-ocular cleft. So a cleft which involves oral, nasal, and ocular processes. That is 3. So you can keep it as 3 structures involving. So the number 3 cleft. So here there are few epidemiological data which has to be taken into consideration. Here the clefts are equal between male and female, unlike your regular normal common clefts. Okay, the right side involvement is 1/3, which is equal to the left side involvement, which is again 1/3, and the remaining 2/3 is bilateral cleft involvement. Here the process starts, the skeletal involvement starts between the central lateral incisor and the canine, and it moves further upwards uh, through the frontal process. So through the piriform rim, through the maxillary sinus. Okay, it involves the frontal process, terminates in the lacrimal groove. Okay, it terminates in the lacrimal groove. So the presentation, clinical presentation, is again a cleft lip, which is paramedial cleft would be present, and there is involvement of the filtral column. Floor of the nose is involved. Deficiency of all alar base might be present, and the lower eyelids are involved. So we can see here there is a cleft of lip, and there is involvement of there is deficiency of the filtral column, and then the floor of the nose is being involved, and deficiency of the alar base is present, and the lower eyelids are also involved. Okay, and when we compare bilateral nose, the height of the nasal side of the involved side is short. This is also to be taken into, I mean, this is also a typical feature for a diagnosis of type 3 facial cleft. So it involves typically all the structures, that is orbital, nasal, and oral, as the name suggests, oro-naso-ocular cleft. Okay, so here another very important clinical presentation would be the cleft as it passes further near the eyes. It involves a lacrimal duct. So there is lacrimal discrepancy, the duct discrepancy due to the due to the blockage, ductal blockage of the because of the cleft which passes through the duct. So this leads to recurrent infection and lacrimal duct blockage and repeated recurrent infections. Okay, lacrimal ductal infection, and also coloboma might be present for these patients. Okay. Coming to the management which has to be taken importantly in these kind of patients, global protection, because in these cases, because of the recurrent infection lacrimal duct, there might be keratosis. The clinical feature, another one which is important when comparing to other is coloboma. This has to be remembered. Even at the mildest form, it just might be present, but we have to go for a CT evaluation which shows the whole complete cleft. So when we go to the next cleft, that is the cleft number 4, which occurs lateral to the nasal region. Okay, and here we can see there is separation of cheeks, which is called melachiosis. Okay, so this is oro-ocular cleft. So the third one was involving 3, but fourth it becomes just lateral to it. So this is the first of the lateral clefts. So this is oro-ocular cleft. It is also called orofacial cleft, medial maxillary dysplasia. It is also known as. And here the presentation is to the right, to the left would be 2 is to 1.3 the presentations, and male is to female is 2.5 is to 1. Coming to the clinical presentation of these clefts, there is a cleft which involves lateral to the cupid's bow, medial to the oral commissus. So it doesn't involve the oral commissions, but it is lateral to the cupid's bow. The cupid's bow gets over here. So the cupid's bow is getting over here, and this cleft commissure is here. So this here is sorry, cleft commissure is here. The cleft is just between these. Okay, so lateral to the cupid's bow, medial to the oral commissure. Okay, there is no orbicularis oris in the medial segment here. So here the muscular support is not there. So then later it involves a cheek and the lower eyelid. Okay, and it can present as micro-ophthalmia or an ophthalmia. Okay, the orbital involvement, it can just range from nothing to a microphthalmia to an ophthalmia. Okay, so skeletal evaluation might show that there is a cleft which involves which extends between the lateral incisors and canine, and it passes lateral to the piriform rim. So here there is no involvement of nasal region. Okay, as we had seen previously, so it doesn't involve. It goes through the maxillary sinus to the orbit, which is just medial to the infraorbital foramen. So again, it has to be remembered 2 landmarks. Nasal structure is not involved, but it is medial to the infraorbital foramen. So it involves the infraorbital rim, but just medial to the infraorbital foramen. Okay, so this is all about cleft number 4. So it just starts between the lateral incisors and canine, extends through the maxillary sinus to the infraorbital rim, just medial to the infraorbital foramen. Moving further, this left side, that is our right side, would be this side is your cleft number 5. Here it's your cleft number 4. So what's the difference? This is just medial to the infraorbital foramen. Here it is lateral to the infraorbital foramen. So that's the main difference. So this is also called Morian type 3 cleft. It's also called orofacial cleft, oro-ocular cleft type 2, because it's lateral, because as we saw in the first classification system, it's divided into medial and lateral depending upon if the cleft passes medial or lateral to the infraorbital foramen respectively. So here the involvement would be again 1/4 of the case is unilateral, and 1/4 of the case is bilateral. Another half consist of any other type of clefts. It might not be necessary that bilaterally it should be 5 5, it should be 4 4. It can be 5 on one side, and the other side it can be 3 or 4, whatever it is. Okay, so that such cases are half the presentation cases. Okay, and the presentation clinical feature would be the cleft begins medial to the commissure of the lips, and it involves a cheek like the previous cleft itself. So when we see the skeletal region, it's between the canine and premolar, unlike your lateral incisor and canine in the type 4. Okay, and it similarly involves the maxillary sinus and to the infraorbital foramen, but just lateral to the infraorbital foramen. Okay, then going further with cleft number 6. So this is your lateral cleft. Okay, so the lateral cleft number 6, if it involves with the radial cleft deformity, it is your Naegger's syndrome. Just a note. Okay, so normally let's discuss about the number 6 cleft. It is also called incomplete Tessiers cleft. Okay, um, so it's also called, other than that incomplete Tessiers cleft, it's also called as maxillozygomatic dysplasia. So here there is involvement of angle of the mandible, lateral palpebral fissure, and the cleft algorithm is zygomatic eminence. Sorry, the cleft along this is zygomatic eminence. So this gives an antimongoloid slant, lower lid ectopion, and colobomas might be present. Okay, so the cleft typically involves your zygomatico-maxillary suture. So this is important in this. There is involvement of zygomatico-maxillary. So there is a typical involvement of zygomatico-maxillary suture. Okay, so there is separation of your zygomatic bone and your maxillary bone. Okay, so this also presents with zygomatic hypoplasia with an intact zygomatic arch. So to be remembered, zygomatic hypoplasia with an intact zygomatic arch. So this mainly involves a zygomatico-maxillary suture. So the presentation is the cleft involves, like, there is hypoplasia of angle of mandible, lateral palpebral fissure, and along with this zygomatic eminence is also less. So the clinical presentation would be an anti-mongoloid slant and lower lid ectropion. Okay, eyelid ectropion. Okay, and colobomas might be present, and lateral canthus ectropion is also C. Okay, and coming to the number 7, which is a very, like, popular one, or popular, say, you can tell it as very common one. So this is one of the most common facial cleft, or rather to tell it as the most common facial cleft, which is your hemifacial microsomia, or it is also called temporozygomaticofacial cleft. Okay, craniofacial microsomia also it is called as. And another name for it is your otomandibular dysostosis, also known as first and second brachial syndrome, or auriculobrachiogenic dysplasia, and it's also known as Golden-Hart syndrome, depending upon its hereditary. So if it is associated with an autosomal dominant um, pattern with epibulbar dermoids, which is present in 1 in 5,600 birth, it is also, I mean, it can be named as a golden heart syndrome. So here the presentation would be oral commissure whitening or macrostomia clinical presentation. Pre-auricular skin tags is a very common presentation. Here you can see, I mean, not in the picture, so you would be able to see pre-auricular skin tags. So it is an incomplete fissure. You won't be seeing a direct communication, but there is skeletal abnormal absent or less facial nerve. So facial nerve, which there is facial nerve discrepancy. Okay, so which is another important point. The parotid gland involvement is seen over the side, and the ears, that might be abnormal, the auricle, or there might be absence. Okay, and the preauricular hair in the temporal region points towards the commissure. Okay, and while the craniofacial microstomia, it has absence. So this is a differentiating feature. So what are the main clinical presentation? There is macrostomia. Okay, that is due to the commissure. What do you call oral commissure widening, and there is preauricular skin tags. There is discrepancy. I mean, there is parotid gland deficiency, or it can be absent, and the auricular region there might be any structural abnormality, or it might be just absent. Facial nerve is involved, so, and the hair points towards the commissure of the lips. So in detail we would be looking into hemifacial microsomia in separate sessions. These are just for, so here it is a combination of 6, 7 and 8. So they occur just not separately. It can occur as a trichocolon syndrome can occur as a combination, hemifacial microsomia can occur as the combination of all these things. That is, the 6, 7, and 8 can be just involved together. So this is also to be taken into consideration. So further forward, when we consider cleft number 8, that is frontozygote. This is not cleft number 8. We do not have an exact picture for it, but I will just explain. Number 8 cleft would be frontozygomatic cleft. So it involves zygomatic bone and the frontal bone. Okay, or it is also called frontal bone and zygomatic bone. So the cleft occurs here. Okay, so it is also called zygomato-frontal dysplasia. Okay, Trichocolon syndrome in severe abnormality, it can have a cleft number 8 also present in combination. Okay, Golden Heart syndrome, which has soft tissue involvement, that is a combination of all these things, also has number 8 cleft. So coming forward, number 9 is an extension of number 6 towards a cranial bone, so it would go through this. So we have seen number 8 is here, number 9 is like this, and when we see further, number 10 is the one which goes like this. Okay, that is, it is an extension of number 4 cleft. So number 4 goes all the way like this. So an extension of this would be 10. 9 was an extension of number 5, which is lateral to the infraorbital foramen. Okay, and the number 11 would be an extension of 3, which is goes involving the ocular, nasal, and the cranial. Okay, so this would be your 11, and the 12 would be not involving the orbital region. So here we can see 11 number, which is an extension of 3, which involves oral, nasal, ocular, and the cranial extension. Okay, and 12. So 12 is an extension of number 2 cleft. Okay, so here the skeletal involvement of the right side of the cleft through the frontal process of the maxilla. Here there might be clinical presentation of hypertelorism, as we have seen in cleft number 2 itself. So to sum up the 9, 10, 11, 12 clefts, 9 is your temporal region cleft. Okay, it goes like this. Okay, 10 and 11 it is to orbit. Okay, and 12 is median to the orbit. I mean, it doesn't involve the orbit, it's like this. Okay, and this is 40 number cleft, which is an extension of, this is a midline cleft, which is an extension of cleft number 0.